all. This is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. So today with us once more, our rock star immunologist, Dr. Bill Murphy. So Dr. Murphy, welcome.
Thank you. Pleasure to be here.
So very quickly, of course, we every time that you're here, we go over your biography. But anybody who's new out there, Dr. Murphy is part of the Department of Dermatology, UC Davis. He's a distinguished professor, vice chair of research, Department of Dermatology, distinguished professor, Department of Internal Medicine, Division of Hematology and Oncology. And if you look at his biography, Dr. Murphy spent his postdoctoral years and early career at the National Cancer Institute in Frederick, Maryland. Then in 2008, Dr. Murphy moved his lab to University of California, Davis School of Medicine. In 2018, he became distinguished professor at UC Davis. Dr. Murphy's lab studies various aspects within cancer immunology and immunotherapy, including immune responses to pathogens. Dr. Murphy has over 250 publications in cancer immunology and immunotherapy over his 30-year career. So what a glowing resume, and you always increase the ambience of Dr. Bean. So thank you very much for being here. We are going to talk about immunotherapy in the fourth arm. So what are the first, second, and third arm? What is this fourth arm?
Yeah, so, for the longest time, cancer treatment, and it hasn't really changed a lot as far as the frontline treatments. The first three arms are, if there's a tumor, it's surgery, you cut it out. And then if the tumor has spread or will spread, then you'll follow it up with what we call cytoreductive treatment. That means it kills cells that grow fast. And this usually involves radiation therapy and or chemotherapy. And what they found with many cancers, it's this combination of all three that are usually applied. For the longest time, immunotherapy, everybody's been very attracted by immunotherapy because the problem with a lot of the cytoreductive radiation chemo is it's not specific. It will kill all rapidly proliferating cells, and that's why if you're undergoing these kinds of treatments, your gastrointestinal and your hematopoietic cells are being affected because they're always turning over. And it was that collateral damage that really limits it. It limits quality of life. And there's only so much of these kinds of poisons or cytoreductive drugs that you can get. And unfortunately, too, then the cancer becomes resistant, and then it becomes it's not going to work anymore. The immune prospect was always very attractive because the idea is, as an immunologist, is the immune system specific. It sees the virus, it sees a pathogen, and specifically attacks it. If it becomes, if your immune system is like too lax and you become autoimmunity, we already know how bad that is. So the specificity of the immune system, people were hoping could apply it to cancer. That's why you hear that word magic bullet by Paul Ehrlich. The magic bullet is that it only attacks what's bad and it spares what's good. For the immunotherapy, though, in the early days, unfortunately, we didn't understand enough about the immune system. And a lot of times the immunotherapy was also very toxic. And so it's only within I'd say in the past, say, 10 years that we've made so many advances with immunotherapy and cancer in particular, that we're seeing what I would consider almost like home runs, where we're seeing controllable toxicities, and we're seeing now long-term responses and cures even, which is usually, you never like to use the C word with the C word. Cure with cancer sometimes is you never really know, but you're definitely seeing 10, 15, 20 years out that the immune system is still working. And that's what makes the immune system so different than, say, classical treatments. You give radiation, you give chemo, you do surgery, that's finite. But the immune system is what we would call a living system, a living drug. And so hopefully when it really works, as the cancer tries to evade, the immune system adapts to it. And that's what makes it now so exciting, is that it can also keep up with the cancer, whereas in the past, when you've relapsed, options were very limited. And so it's this concept of using the immune system. Unfortunately, as we talked about last week, it's not a one size fits all. many different types of cancers, and I can give the same, whether it's a vaccine or anything, to everybody, and we're all going to get different immune responses. Our immune system is affected by our age, our health, our genotype, as far as our history, what we've been exposed to. And so that makes it a very complicated system to try to exploit in attacking the cancer, because everybody's immune system, that's what we call personalized medicine in a way. Your immune system is almost better than a fingerprint as far as it's so unique to you that it's, we have to be very careful when we try to extrapolate it to the general population of a type of therapy.
So tell me this, when we are going to help through the immune system,
Mhm.
why not in the first place when the cancer is occurring? Does the immune system take over and help at that time? Why do we need to augment this or help it afterwards?
Because if you may recall last week when we talked about cancer formation, it starts with just some mutated genes. So the immune system is all geared for what we call danger. All right. It's called the danger hypothesis in the sense of when we get an acute viral infection, our immune system has never evolved to fight cancer because most people get diagnosed, I mentioned last week, get diagnosed with cancer over the age of 55. And for the most part, up to, say, the advent of antibiotics, most people didn't live beyond that. And so cancer was not a system, the immune system was not evolved, it was fighting for infection. And the danger component is that what we call toll receptors or non-specific inflammation. That gets things going that the immune system knows something's wrong. Usually, like when a virus comes in, it infects the cell dies, it lyses, and it causes all these inflammation. That's when your immune system says, okay, let's get specific, let's kill. Cancer doesn't work that way. Cancer is very insidious, it occurs slowly over periods of time, and it arises from self. All right, so the changes that occur in cancer are very subtle. These are like simple amino acid changes on a protein that we normally have and are tolerized to, because the immune system is all geared for control. It doesn't want autoimmunity, so it's gone really beyond. So when the cells start to mutate, the immune system doesn't see anything there, and the cancer is certainly not helping it. The cancer is actually trying to suppress the immune system and be stealth. Some cancer cells are actually very good at pirating the immune system and saying, help me grow. And so those are the things that make it very difficult to expect the immune system to work. Now, that being said, the immune system probably does play a role. That's the immune surveillance theory. We know transplant recipients who are immunosuppressed, they have a higher incidence of some cancers, right? So there's definitely the immune system may be keeping things at bay, but the breakouts are what we have to deal with because also, as you may recall, as we age, our immune system doesn't work as well. Well, that's also when we're getting cancer. So it could be that the immune system is controlling, not eradicating. And then eventually, as that decreases and the tumor increases its aggressiveness, that's when we have to come in and amplify.
That's very interesting. So, so imagine that there was a person whose immune system was working, then at some point it got diminished and the cancer kind of spread. How do or grew? What do you do in the immunotherapy? How do you target that cancer?
Right. And that's always been the holy grail, as we call it, finding that. So the whole point of the immune system is it has to see something different. It's different than what it's used to as being yourself. And the problem is with cancer, these are very small changes that occur over time. And so sometimes the immune system is not used to seeing that. In the initial stages, the early immunotherapy, it was noticed that people sometimes with infections, if they had a tumor, the tumor got smaller. And so they were using ways, and we haven't changed a lot. Sometimes what we use like we call these adjuvants like in vaccines. We give something that will non-specifically activate the immune system, and then we use some of these same kinds of approaches in some cancers. We just give what we call an adjuvant. We use BCG in bladder cancer. Some of these things that are, just non-specific, and we're seeing that applying some of these toll receptor agonists jumpstarts a bit more the immune system, saying there's danger. And so that's what was started. But now we're learning too, maybe we can also jumpstart an existing immune response. And that was a whole new concept that got the Nobel Prize several years ago for a checkpoint block, which we can talk about, in which we see the immune cells in the tumor. And we've seen that for a long time. We know if we see a lot of T cells, for example, which is the hallmark, that if there's more T cells in there of a good kind, patients do better. And now the question is then in the early stages, people would take those T cells out and say, how do we make them better? And so the immune system right now, what we're trying to do is see what we can do to amplify an existing response as well as keep it going, because we know that just like with a virus, that cancer is going to try to evade. And that's been the big issue is because what you want to worry about is the metastasis. So when a tumor is metastatic and it's gone to vital organs, then it's a race, right? For a lot of times, the immune system is used to a virus which will cure or kill kind of a thing. With a cancer, it can wait, and it can be in areas where it's constantly changing, and that makes it very hard for the immune system to keep up with. And so, what people are looking at is, and what we work on is what we call, and we can talk about that later, CAR T cells. You'll hear about that, in which we take your immune cells out, genetically alter them so they can actually specifically attack, put them back in, and then all of a sudden you can now see eradication because you're giving all these cells back that are specific. So sometimes it's literally, unfortunately, with metastasis, you're dealing with huge amounts of cells in different areas, and the immune system literally can't keep up and gets overwhelmed.
Understood. So this is very fascinating. It is something that I read about and I think about. It's such an interesting area. So I have one more question. Imagine that there is a patient who has a cancer and we're going to do immunotherapy. I suspect that we take some cells out of the patient first.
No, not always. It depends on the immunotherapy that you want to apply. So there's two kinds of immunotherapy. There's active immunotherapy in which you're actually trying to use the immune system and allow that to keep going. Passive immunotherapy is actually, well, that was approved first. It's just giving antibodies. So like if you have a B-cell lymphoma and we know there's a marker on it called CD20 or CD19, you give an antibody like Rituxan and that will eradicate the tumor. So antibodies passively can target, and that can be a great tool. And so people have been using that. They actually put poisons on the antibodies like ricin, or they put radiation isotopes on it, and hoping that that will reduce the tumor in a specific manner. The biggest problem with cancer, one of the biggest problems in my mind, is the lack of targets that are specific for the cancer. And so for some tumor, and people get confused by that because there's what we call tumor-specific antigens. That means there are mutations that only that tumor has. And unfortunately, these are not very immunogenic. The immune system doesn't see them well, but they're specific. And there's what we call tumor-associated. That means the tumors have a lot of them, all right? And we can use that to our advantage, but we're going to have some collateral damage. And so one of the viewers asked last week, said, why are we seeing lymphoma being looked at all the time with cancer therapy, immunotherapy? Well, the reason is that's a cancer-associated, tumor-associated antigen. It's on the normal B cells, but it's also on the lymphoma or leukemia. But the thing is, you can live without your B cells. And so a lot of these therapies will target the normal cell as well as the cancer. And the offset is if you have a leukemia lymphoma, that is an acceptable problem. So the CAR therapy, for example, it attacks any B cell, cancer or not. But if you have advanced leukemia, relapse, or whatever, that's acceptable. And there was just a paper where these people don't have B cells for 10 years. All right. But you can give them intravenous immunoglobulin, all right, to keep them going. The problem is, unfortunately, for the non-liquid or what we call hematopoietic cancers, we don't have those kinds of markers. If you have a solid tumor like breast cancer, prostate, colon, unfortunately, you cannot attack the normal cells because that will be unacceptable. You can't live without that. And so that's why you see some of the successes for these other kinds of cancers, because even if it attacks the normal cell, in fact, some people have made a list of organs you can live without. And if you have metastatic cancer, that's okay to attack them both. But with the solid cancers, because they occur over long periods of time, have a lot of subtle changes, it's hard to find that specific target. And that's the big problem is then how do we exploit that? And that's probably where the next big push is as far as using the immune system so you can keep up and attack those.
That's so. This is again fascinating, and I wanted to dig a little deeper on this one. This was a big question, that how do you isolate a cancer cells and an antigen on it? That must take a lot of research. So, are there more generic antigens that are being found, that we say that, well, if somebody has a cancer in a liver,
Mhm.
then here are the set of antigens that mostly are present on these cancers and we can target them? Or do you have to figure out a specific antigen per cancer per person individually?
No, actually, so a lot of cancers have common what we call driver mutations, or these are oncogenes or anti-oncogenes that, like for example, P53, RAS. RAS is a big one that's on many different kinds of mutated on many cancers. And people, there's two approaches. One is you try to find drugs that will target and suppress, because a lot of these oncogenes or the mutated genes are basically enzymes or proteins that cause the cell to keep growing or to evade certain things. And if you and the cell needs that, the tumor cell needs that, and they're mutated. And so what people are trying to do is find small molecule drugs to actually block that, or look at an immune response. Now, but the problem is, again, as I mentioned, as opposed to a drug, everybody's immune system is different. Everybody's components, the MHC and some of these other components are different. And therefore, what your immune cells can see with the same mutated antigen on your cells may be different than what my immune cells can see on my, and it could be the same P53 or RAS mutation, and it's all in colon cancer, but our immune system is different on how we're going to respond to that, and, or not. And so that's where it becomes more personalized, trying to figure out. But people are looking for these common antigens, all right, that are, and then saying, can we now make a cocktail of T cells or a specific, and then, because the other thing to keep in mind, the cancer has evolved to such an extent. Remember, most people, when they are diagnosed with cancer, again, it's older population, and a significant percentage of those, it's already metastasized. That means the cancer has already evolved or devolved, so to speak, such that it is just randomly mutating and changing. There's no rhyme or reason. And then whatever one actually is not selected against wins. All right. And so what you're going to see is in a cancer, it's not clonal. You're going to see 50 to 100 different antigens in different tumor cells within that tumor. That makes it a problem in the sense of trying to target one. All right. And so you're really trying to figure out ways to amplify the entire immune response.
That's very interesting. So, as we age, as you were saying, that as we age, we have the thymus involuting. The is it the selectivity? For example, when you said that I would respond differently than your immune system,
Mhm.
is it the selectivity? It is the binding regions and the variations of those, or it is the whole immune system itself acts like
Oh,
a fingerprint?
yeah, the whole immune system itself, because as we age, our ability to make responses to new antigens, even to vaccines, I've seen this with flu vaccines and everything else, decreases dramatically. And then our immune system relies on what we already have and sort of says, well, that's close enough. So, what most people don't realize with the immune system, everybody thinks it's very specific, lock and key, but it's actually a conglomerate of different kinds of affinities, some high, some bind great, some not so great, and the immune system use what it has to get a general picture. And some of them are going to be more efficient than others, depending on how robust our immune system is at a time. Some people, maybe if they're like all of us have been, most of us have been exposed to cytomegalovirus, CMV, and EBV. All right, and they're seeing this now correlating with MS and other kinds of diseases. These viruses are latent. That means we have them and we will always have them. And our immune system is keeping them at bay. And that's why a lot of our immune system is directed against these viruses, right? Significant. And yet that means that we have less to respond to other things, all right? Because the immune system is also all about, they compete with each other. And so if there's something triggering this virus specific T cell, it's going to say, I need to be here. You other ones that aren't doing anything, you don't. And if it's to a cancer, well, unfortunately, that's something we're losing.
Oh wow! So that means that immune system distractors can cause a cancer cell to sneak up and start growing without check?
Well, what it can do is it actually, I don't know if it's going to cause it to grow. It's going to grow anyway, but it's going to minimize the potential immune effects such that we need to then jumpstart that. And that's why, a lot of times they're saying, when you're getting vaccinated, or whatever, you don't want to do it all at once. I know for practical reasons, but for the most part, you want your immune system to really crank to a particular antigen at a certain time. And that's why even like vaccine responses diminish over time, right? Why do they diminish? Because other things are crowding them out unless they're getting stimulated again. So that's why we have to constantly get boosted. Well, cancer is trying to avoid, it wants to avoid detection. And so by that criteria, the immune system a lot of times isn't really recognizing it enough. And by the time it does, it's usually too late.
Understood. Understood. So then tell me this. Do you think that the future of the medicine will actually be that immunotherapy will be the first arm instead of the other ones?
Well, that's a really good question. And that actually is being looked at as far as because prior to, I would say, I don't know, like I said, about 10 years ago, immunotherapy was also very toxic. As I mentioned to you before, I had a friend of mine who was an oncologist, and he had melanoma, and he actually died from the immunotherapy, not from the cancer. Um, and so a lot of times we have to be very careful. The immune system, again, is a living drug. And sometimes once we jumpstart something, it's hard to control it. Now, some of this can be acute, like for example, even with COVID and with some of the cancer therapies, we get what we call cytokine release syndrome, which means the immune system is just going so fast, it's causing a lot of toxicity. But other types of immunotherapy induce what we call an autoimmunity. So, in other words, the immune system is just now, we take some of these breaks off. And yes, the cancer is being attacked, but then we get autoimmunity. And that's also, it can be very toxic. And so it was only within, like I said, the last 10 years that the reason immunotherapy was used later is because it was so toxic and hard to control. And it was a last resort. Now that we're finding particularly with checkpoint therapy again was the Nobel Prize several years ago, and that's where we found we could give this kind of PD-1 or drug antibodies to block some of these immune checkpoints. You can give it to people of older age, whereas before, as with chemo and radiation, you can't treat an 80-year-old the same as a 30-year-old. But some of these immunotherapies you can, and you can get this systemic effects. I think the biggest thing with immunotherapy that's changed the playing field was this checkpoint, which is anti-PD-1, PD-L1, and you'll see advertisements on TV for it by all the different names. The biggest problem that we had before when we were applying immunotherapy is we thought the immune system was suppressed, and so we tried to jumpstart it by giving it what I call gasoline, and we were trying to give more of these activating factors, and it was causing a lot of toxicities, and it didn't work very great. What made this so revolutionary is they found, well, wait a minute, the immune system always tries to turn itself off, because if you have a viral infection and you know how bad you feel, and if it keeps going, you're dead. The virus isn't killing you anymore, it's immunopathology. So the immune system has these brakes, and these brakes are very potent. And anybody that tries to do a car, if you put your foot on the gas and your foot on the brakes at the same time, you're not going very well, right? And so once we found you could just take the brake off, now all of a sudden we found that the immune system works much better and much lower toxicity. And that was really the hallmark. That's why I got the Nobel Prize. And that's now the standard on a lot of cancers. What made checkpoints so revolutionary, it worked in lung cancer where nothing worked. So one of your viewers mentioned, well, lymphoma. Yes. So classically, immunotherapies usually work for lymphoma, melanoma, renal cancer, and some others. Lung cancer was tough, and checkpoint works in that. Now, it's important to note when I say it works, I'm saying that you can get a significant population responding and some long term, but it's not universal. It's not, like I said, everybody's immune system is different. And that's what we need to figure out more is we need to figure out how do we get a picture on your immune system, your status, to figure out what to apply it to? What drug to use, what kind of regimen to use, because it's not all going to be the same. And that's the big area right now, is figuring out in some patients, why do some respond once, some don't.
Very interesting. So can I, with your permission, dig a little more deeper?
Mm-hmm.
So the PD-1 and PDL, so these
Yeah.
are the programmed cell death receptors, and the PDL is a ligand for that. So they are related to apoptosis. So if we are
Well,
modulating
yeah, not necessarily. No, and so sometimes
cytotoxicity,
no, it's actually more a break. So PD-1, PD-L1 does not induce. It's probably sometimes when things are named, they're named on how they reacted on a cell type in question, and it can play playing a role. But with regard to T cells, PD-1 acts as a brake. It actually dampens the T cell response. All right, and it plays an important role in keeping the T cells around. Normally, like I said, we need that because we have our cells like to CMV, the virus-specific cells. Some of these will have PD-1 because you need some brakes on. But in cancer, we want to take the brake off. And by taking the brake off, all the PD-1 checkpoint does, well, one of the many things it does, it causes those T cells, because the cancer cell actually is very smart. Some of the cancer cells will actually express the ligand for PD-1, and that causes the T cells, even when they get to the tumor, they turn off. By blocking it, now they can kill. So the
so it
last
is the exhausted T cells.
yes, that's where you hear the word
It,
exhaustion.
it unexhausts them.
Yes, that's exactly right. But it does more than
That's
that. It actually seems to also reinvigorate even new T cells, making them respond better. So actually, the PD-1, PDL1 story was actually originated with HIV and virus responses. That's how we learned about it. And that's how we learned a lot about how to apply immunotherapies, through a study of viruses, because that's the same pathways, same cells, and a lot of times the same control mechanisms.
interesting. So then, how costly or not costly, how affordable is this technology, this treatment?
So, any cancer drug is extremely can be extremely expensive because of what it takes to develop it, even though what we call the small molecules or molecular targeting agents. So when you're seeing people a lot of times are for many kinds of disorders, whether it's an autoimmune disorder or colitis or Crohn's, you get antibodies. These are monoclonal antibodies to cytokines to block the cytokine from eating the pathology. So antibodies cost money to produce, because these are not things that you can just easily make, and to administer because they're given intravenously. So these can be very expensive, but really expensive are when we start using some of these new cutting edge technologies, like genetically modifying, like what we're doing, genetically modifying the T cells, the CAR T cells. Well, that can cost about $500,000 just to get, because I have to take your cells out. Then we have to actually do a genetic engineering. Then we have to grow these cells up under very controlled conditions, all right? And then we have to infuse them back into you. And this is a very expensive procedure. So immunotherapy can be extremely expensive. The other problem is with immunotherapy, like with checkpoint, with PD-1, when do you stop giving it? So, for example, if you have cancer or metastatic disease and you get this checkpoint and you're not getting a lot of toxicity and the cancer goes away, do you stop? That's a really good question, because as opposed to a virus, and even some viruses, as we know, can be latent, maybe the cancer is just waiting. And so this is a theoretical question that is still being addressed, as far as if there's acceptable toxicity and the cancer has regressed such that you don't see it. Because how do we know the cancer is gone? It's usually by looking at the scans for the tumor mass to shrink. But that doesn't mean the cancer is really, we know it's gone, right? And so then the question becomes, as far as, do you stop that? But then the other question is too, by constantly taking the brakes off your immune system, that can't be good either. And so eventually you might get autoimmunity later on. So these are questions that a lot of times, it's sort of like the Titanic. When the Titanic's sinking, you jump off the ship, okay? Yes, you off the ship, but now you're in the water, all right? Okay, great. Okay, now you're in a lifeboat, but there's no food. So it's a matter of time, and severity. So these are things that we're trying to wrestle with as far as because of the cost. All right. Are these drugs that are going to have to be chronically delivered or what? Same thing with the CAR therapy. How do you turn it off? Right. And so these are all things that right now, if you have metastatic disease, you're not thinking, and your physician's not thinking about that. You're thinking about immediate needs. But then we have to start thinking about what is sustainable, both from the financial, but also from the patient health reason. And it's going to probably be a cost benefit ratio depending on the cancer type.
Got it. Thank you very much. So, a few questions from the audience here. I'm going to start from the latest and try to then dig through backwards. So, here Faraz says, how does hormesis pertain to these mechanisms? So, where
Well,
the effect becomes reversed and harmful from beneficial at certain dose.
yeah, and so that's why it makes it very difficult with immunotherapy because the thresholds will be different for all of us based on just like what we see as far as collateral damage on almost anything. How we take any drug, it's going to be different in our immune system. And not only that, it's important to keep in mind our immune system changes every day. So even how I responded last year, I'm not the same. My immune system is going to be different, and we have to take that into consideration. So a lot of times it will really be based on the what we call the therapeutic window, as far as
Got
what is the extent of the tumor reduction, what is the nature of the cancer. Some cancers, like indolent lymphoma, are so slow growing. Depending on your age, you're not even going to be treated because it's just not going to be probably the major issue versus an acute or a more aggressive disease. And it also
got
depends on the type of cancer. If you have a pancreatic cancer, where options are very limited, versus a lymphoma, where there are a lot of options, that affects your algebra and what you're going to be and how you're treating.
Understood. Thank you very much. One more question. Uh, Nipa says, is cancer a mitochondrial metabolic disease? Can it be controlled by removing the glucose and glutamine in diet? Does water only diet have any effect on cancer cells?
So, this is a whole topic in itself. The metabolism of cancer cells, again, it depends on the cancer because the metabolism is usually contingent on growth rate. And so some cancers grow very fast, some cancers grow very slow. It's kind of ironic because the fast growing cancers are actually usually easier to treat because there's a differential that you can exploit where the slow growing cancers are tough to treat. As far and then there's the complicating thing as far as again, I'm an immunologist. Everything then to me refers to the immune system. There is nothing that is truly specific. It's just going to be a matter of degrees. So then the question is when you're removing the glucose and glutamine, how's that affecting your immune system? Because you may be affecting the cancer, but you're also hurting your immune system. So one thing that I work on is called I work on obesity and cancer immunotherapy, and there's something called the obesity paradox. Obesity is definitely a bad sign for cancer. It causes the cancer to grow faster, usually correlated with greater incidence, poorer outcome, poor response to therapy. But with some types of immunotherapy, like checkpoint, high BMI patients respond better and they have better overall survival than the low BMI patients. So you have to keep in mind there's always that balance between what's a direct effect on the cancer versus it's your immune system that ultimately will probably keep it at bay because the cancer will always constantly change metabolically to try to adapt and live with less. And so that's going to be very difficult then from a dietary standpoint to manipulate and really control for.
Interesting. Thank you very much. Uh, Husky Mom says, any updates on PD-1, etc., in treatment of hepatocellular cancer? Levertinib as a second line for treatment already had AB regimen and AFB went up again. So not a personal advice here, but any updates further on PD-1?
Well, PD-1 is now, it's funny, some people, some oncologists are calling PD-1 the new aspirin, that, we're going to just apply it to everything. The problem is by just applying it to everything, we're not necessarily using it correctly. And so a lot of these things are being done through clinical trials where we're trying to figure, it's not just giving it, it's giving it at the right it's basically an equation. How do you apply it with other types of therapy? Because usually you're not just getting immunotherapy, even like for breast cancer and you're getting hormone blockade. And then also with like with breast cancer, Herceptin, there's certain antibodies to certain growth factors. So you're basically, it's going to be a matter of with every cancer type being informed as far as there's what's approved, and then there's the clinical trials. And that's usually when you look at a comprehensive cancer or the American Cancer Society websites, you get a feel for what's out there that's cutting edge. Because a lot of times with immunotherapy, we can't treat all immunotherapy the same way because every cancer is different. And actually, the age demographics are different and the causes are different. And so it's not a one size fits all. And so I think that's what you're going to have to look at with your particular cancer types.
Understood. Thank you very much. This question is interesting. So for us, is meaning of this paper, macrophage diversity enhances tumor progression and metastasis. So what I did was I quickly searched it, and here is this paper.
Yeah.
Any comments?
Yeah, it's very common. So there's a dual hypotheses. There's what we call immune surveillance theory. That is, the immune system is constantly looking for the cancer cells and killing it. And then there's the opposite called the immune enhancement theory. That is, the same immune cells can actually help the cancer. And so macrophages, and we call TAMs or tumor associated macrophages within the tumor, can form a dual purpose. It's the same thing with inflammation. Inflammation can cause cancer to spread and grow faster, progress faster, but that same inflammation also activates your immune system. Macrophages are pretty much what I consider a mediator of inflammation. The macrophage can actually help the cancer because macrophages will make growth factors for the cancer, and the cancer is really good at pirating because macrophages are what we would call supportive cells. If you get a wound or something like that and your skin has to repair, macrophages come in and they help facilitate the process, and they help make new blood vessels, and we call that angiogenesis. So the macrophages normally are meant for some of these situations. The cancer, though, has pirated them and says, okay, we're not repairing anything. You're just helping me grow, and I need to spread. So the macrophages definitely can do that. So macrophages in almost every disease state, and we look at macrophages in Alzheimer's, you look at it in any kinds of states, they actually can be negative because they can be pro-inflammatory, and they can help tumor spread and also tissue damage. But they can also be very good because these are the same cells that can then take the tumor antigens and tell the T cells, hey, attack this pathway. So there are subpopulations of macrophages which are good and bad, and it's just a matter of then figuring, can we exploit that? And there's been a lot of groups looking at that. The problem is, again, it's a very dynamic, changing environment, very plastic, and it's not all or nothing. And so some people have actually looked at depleting macrophages to actually help suppress the tumor growth and maybe help the immune system.
Understood. Thank you very much. So there is a question that I am not going to show on the screen, but I know that this question has some concepts picked up from some other cancer therapy discussions. The question's gist is the following: that it seems like the cancer's therapy itself is the one that causes cancers instead of helping it. Is this a correct concept?
Well, some of the chemotherapeutics that are used also cause mutations. And in some people, what they found is they can get secondary cancers that were caused by. So you're exactly right. When you say the word radiation, and you say the word, giving a drug that is basically causes mutations, that can cause cancer. Okay, so that's where the thresholds come in. When they're giving these drugs, they're giving high enough amounts that you're hoping to kill the cancer. But you're also exactly right too. Radiation actually can cause the tumor to shrink. It also causes the immune system, though, to now, because those tumor cells, some of those are dead, they pick up the antigens. So radiation now is appreciated to cause an immune response that can also help. So you're exactly right. There's that philosophy, there's nothing either good or bad, but thinking makes it so. every single immune component can be used as a positive or a negative. It's just going to be a matter of the net on how much we can push it over to one side. And so that's the tricky part. Just like obesity can be bad, but we can also use it to our advantage.
Fascinating. That is so interesting that not and nothing is absolute to say this is going to
Yeah.
only be helpful,
Right. And
right?
people have a hard time with that concept because you're giving sometimes a radiation and chemo a poison, but it's doing something good and it's helping the immune system. But at the same point, it also causing inflammation could be helping the cancer.
Understood. Thank you very much. A few more questions. One question that I wanted to ask is the again in this designer drugs for cancer, the messenger RNA based technologies. How do you see them helping or not helping or growing or evolving in this area?
Well, as I think you and I have talked about, mRNA vaccines were actually initially applied in cancer before we started using them for viruses. And so that's how they were actually developed and tested initially. The problem is vaccines, as a rule, don't work very well because the vaccine is not strong enough. By the time you have advanced disease or metastatic disease, it's basically you need to have a massive amount of immune cells capable of keeping that cancer at bay. So I don't really see it myself as playing a major role, and at least for some time being. It may eventually, but for the most part, what people are looking at now is using, like some people actually believe in, give oncolytic viruses to actually kill the cancer cells and activate the immune system. Using that in brain cancer and some other cancers. But for the most part, you're looking at immune cells being given or amplifying it systemically that way, maybe with vaccines in the future, but for the most part, they're not strong enough to elicit a lot of effects.
Understood. Thank you very much. And one last question. Uh, Husky Mom says, is there still a place for chemo embolization and or radio embolization or cyber knife?
Definitely. So a lot of times what we're finding is you still have to reduce the tumor burden. So so the bottom line is some tumors they'll be operable, some will not, especially metastatic lesions. And you basically, I think the thinking is for the immunotherapy, we either need to come in earlier before the tumors are too big, or we have to reduce the tumor's burden enough such that the immune system can mop up the rest. Because and actually the initial CAR therapy studies actually showed that the children with leukemia had huge tumor burdens because they relapsed and they got the CAR therapy. And some of them almost died because so many tumor cells were being killed that it's called tumor lysis syndrome, as well as the cytokine storm. It overwhelmed the body. And so you still need these treatments to make the target more manageable for the immune system because it's still going to be. So I see it more as just like with like triple drug therapy for HIV, you give 3 kinds of antiretrovirals. Now we're seeing immunotherapy being as a part of the question that attacks the cancer, but we have to be careful because some of the chemotherapies that we give can be also immunosuppressive, right? Because they kill immune cells as well as, and some of these are actually used in autoimmunity. And so we have to be very careful on how the timing is going to be key. And that's going to be contingent on also then the patient's immune system and the cancer and how aggressive it is.
Got it. Thank you very much. Um, I just see one more question, and I know we are at 45 minutes, so let's make this one the last one. Daniel Ao says, how effective is removal of lymph nodes in managing a metastatic cancer?
Yeah, and again, this depends on the cancer, but most cancers start by spreading through the lymph nodes, which again sounds like counterintuitive. The lymph nodes are where your immune system is, right? And so you would think, well, wait a minute, that's what we want. Why would the cancer even go there? But that shows you how also good the cancer is as far as evading. So most cancers, and that's how we do staging and grading, is if regional lymph nodes are involved, because we know that's where they start, and then it can eventually metastasize to distal lymph nodes and distant organs. So it's usually considered still a pretty important therapy because, again, that comes to the same thing before. You want to get rid of as much of the tumor where you know it is as possible, and then use the immune system to then manage whatever is left. And sometimes we call these, when it's going after like micrometastasis, we don't even see it, but you can detect it by genetic testing, by PCR and things like that, that there's tumor there, but you just can't see it. And that's where you want the immune system to be very good at going after it, not where there's actually tumors you can see in the lymph node. You want to get that out.
Understood. So thank you so much. Thank you for your time. It is such a wonderful discussion, and it's so great to listen to you. I can actually keep going, and I think that you can keep going as well. Thank you very much for your time. Hopefully, we'll do another session soon.
Definitely. Thank you very much.
Thank you very much. And Cool Beans, thank you very much for your time as well. I would see you tomorrow. Please, if you can, like, subscribe, and share. And if you would like to support this work, there are links as well in the description. So with this, thank you, and I would see you tomorrow. Bye for now.